All right, so welcome to this last part of this marathon lecture. Let's see if we can get through this as well. This is about, well, we talked about adults, emergency orthopedic, like the entire area, I think, or at least 90% of it, what is relevant for emergency physicians. And now we're going into the special groups, and I'll start off with the pediatrics, and I'll end with a bit of geriatrics, but mostly with a few references. And we'll delve into a bit of the major traumatology, some links for that. Okay, so let's start off. So if this is how the adult injures themselves, we all know that this is how the children usually injure themselves. All right, trampoline accidents. So let's go and let's get into it, and I'll try to start off with just mentioning some of the differences between adults and kids that come in that are relevant for us as emergency physicians handling orthopedic injuries in these ages. Okay, a lot of this I have from a lecture from the course that we attended. So I thank Andreas Sulvan a lot for these tips, and we will, we'll especially the five tips in the beginning. I thank him a lot for. Okay, so let's move on. Um, all right, the 5 tips about the children. So kids are small adults, but so the first one is the physis. All right, the physis. So we have this. We talked about the adult bone and the pediatric bone a bit earlier in this lecture, and one of the differences is that the pediatric bone is growing, right? So they have a metaphysis and a physis and an epiphysis. The physis is the growth zone, and there can be breaks in that, and it's important to know the what you call the Salter-Harris classification, because if it breaks through either into the joint or is like is the growth zone is destroyed, then it's a difficult fracture, and usually has to be operated on, and stuff has to be done, right? And the Salter-Harris classification here can be remembered as Salter. So a Salter-Harris group 1 is just a straight across fracture. Then there's the above the growth zone fracture, which is a 2. Then there is the below into down here. Then there's a 1 through. These are the more serious, especially the serious ones, right? But this is like, if you remember, this is a Tilo fracture. So some of these might be operative or might be non-operative, but really need to be caught as well. And then you have this one. This is destruction of the growth zone, and that's quite hard to catch. So straight, above, lower, through everything, and rammed. There's different kinds of versions of this, but something like that. Okay. Then it's also important to know that, yeah, the metaphysis, this area measured like as a rule of thumb, the width, and then the width, if that's x, then the width also in height, that's x as well. Then you get a square, and that square is the metaphysis area. Okay, something like that. And the metaphysis, like bricks in the metaphysis, is magical, as Andres Sulvan at our course said, like the magical metaphysis, right? Because injuries to the metaphysis, especially in high growing areas such as the shoulder or wrist, can straighten up. So you can have a massively displaced fracture in children, but it will grow and it will fix itself at 1 degree per month. So if you have angulation of 30 degrees, then it takes 30 months. And there are some studies showing that in the time, it actually doesn't. You can manage non-operatively, and the function level of the children being operated on versus the ones non-operated on are generally kind of the same. It's not like as it's growing, it's getting into more trouble than if you operated on it. I guess there's some exceptions, but in general, you can often, like as a rule of thumb, you can often treat a lot of the metaphysis um, breaks totally conservatively. And you will see that in guidelines that you accept much more angulation, especially around the metaphysis. Okay. Um, though the diaphysis, the shaft, that is not magical at all. The growth has stopped there. If it breaks here, then it's usually something that has to be dealt with, right? Either operatively or not. It's much more like the adult breaks. And also rotations are not accepted at all. It cannot fix rotations, and it cannot fix diaphysis. So it's just the magical metaphysis, right? Not anything else. Um, and it's also important to know about these, because of the physis, there are certain breaks or there are certain problems that can occur in children that cannot occur in adults. And one of them is the epiphysiolysis, which usually happens in prepubescent or pubescent, like 10 to 13 years old, I think. Usually a bit overweight. Late bloomers, usually male, that's the classical presentation, that don't want to run during gym class and has a bit of a limp when they're walking, and they might at some point jump from a horse or jump from a tree, and then there's a trigger like that probably slips it off. So that's and that will risk getting their hip into a necrosis. So that's epiphysiolysis, and it's an important condition that we'll talk about later. But this physis does make of this both like magical, but it's also you have to take care, like make sure that it's not that the growth center is intact, and take the Salter-Harris into account as well. Okay. All right, that's the first one. And just wanted to show this magical metaphysis. Here is an adult bone though, but it's the width, and then the metaphysis is around this, like what you would call this area. Okay. All right. Then kids are small adults, but the ligaments beats the bones generally. Okay, so it goes like this: like kids, the bones are quite soft, right? Especially with smaller kids, and then the ligaments are the more tough structures. So what you will see when you pull on a ligament, then on an adult, usually it will break the ligament because the bone is stronger. But here you'll see much more avulsions. You'll see much more smaller breaks because the ligament is strong, but the bone is not as strong. And then you'll see these avulsions. This is what you call a Sagond fracture, which is usually from an ACL rupture, or what would be an ACL rupture, or but doesn't necessarily become one. But and then if you want to take the analogy all the way, then like kids, the ligaments are really strong, and so you get avulsions or you get breaks other places. For the adults, you will have the bone is strong, so the bone will break. The ligaments will then break, and with with the elderly, then the ligaments get so laxed sometimes that you will just get you won't get any support from them, and then or very very limited support, and then you'll get some bone on bone problems usually. So an example is here that you will get a lateral condyle fracture if you have an injury where the bone is pushed from here to here. Then you can get a lateral fracture here. As we talked about lateral tibial condyle fracture, because there's no support in the MCL anymore for the very old. Yeah. Okay. Then we have this thing about ossifications and versus avulsions. An avulsion can look like often you will see a small like thing on a on a picture of a child's elbow or a picture of a child's knee, and you're wondering, is that an avulsion? Of course, you need to think of the precise probability. Does it hurt there and so on? But if it fits with the clinic, sometimes it's hard because they have all of these ossification centers, and so there are several ways of like trying to check whether or not it's an avulsion, or it's like a brick, or it's just an ossification center. And in general, avulsions are more like, if you look at how it looks, usually it's a more rough. It's not smooth around all around, and that's like a general rule. Also in adults, when you see calcifications or something like that, they're usually more smooth around. And you have to be able to see them in two pictures, right? 90 degrees between each other. But you can also, other tips are to check the opposite side. That's why it's often done in some children, to check the opposite side, whether that is an ossification center or not. There are some mnemonics in different areas, because you can, depending on what age the child is, you know what kind of ossification center are done or are beginning, and which ones are not there yet. And then you can kind of work your way out, work out how, whether that is an avulsion or it's not. All right. So different ways of going about this. I'll try to show you. All right, so here's just a normal elbow of a child, and we wondered how old this child is. This is from Don't Forget the Bubbles. I'll get you the links soon, so you can do more quizzes if you want to. But this is so this is a child's elbow, and how old are they? Well, we get our crito, or we might as well just get a picture besides. And how old is this child? Well, there's a C, that one is there. And there's the R, that one, head of the radius there. There's the I. The I begins to form out here. And then there's, I'm not sure. I don't think there are any. The T should be here. I don't see one here. And I might have missed that, so I'll go to the O. I don't see any O either. And there's no O here. So definitely below 9, and I think also below 7. All right, so that's the C, and that's the R, that's the I there. So these are quite easy to spot. And that's also the case from Don't Forget the Bubbles. That's what they found. So this is a child of 7 years of age. Let's try another one. Now we know the age of the girl. This is usually we don't have to guess the age of the girl. We're not forensic detectives. So, but here's the a 12-year-old girl, right? And we see the girl has a Furcht, so there's pain in the elbow region, and let's see if we can. So there's lots of bones, and there's lots of potential ossification centers. Is that something, or is that something, or so we'll just try to go through these, and if we lay over this, if we lay over these. This rule, we'll just see here that. All right, so we're checking out. So the C, yes, I was there, and oh, sorry, it's moved. It's mirrored this time, so it's a bit harder. But I guess this is the C. This is the radial head. Then this is let's see, the I is out here. Sorry, the I should be here. There should be an I here. Right, because it's mirrored. There should be an I here. There's an E here. And there's a let's see, might be a T there as well. So it makes sense that she's around 12. But it seems like the I, right? Remember it's mirrored. The I should be here. I don't see an I. There should be an I. So where is it? Let's see on the other one here. Seems also a bit weird around the eye around here. So let's check it out. So yeah, you have your C, your R, your I should be there, and your T, your O, and your E, crito, okay? But the I is missing, and in this picture there's an extra one here, right? So is this an avulsion? If you look at it, it's a bit rough down here as well. It does live up to that rule as well, and in this picture it does look a bit rough here as well, right? So that's kind of how you use the rule. Check out these pictures, and it's especially difficult in the elbow. That's why the mnemonic is there, but it goes the same way in the other joints, right? Okay, kids are small adults, but um, just there's always like no, depending on the room that you're talking to. If it's pediatricians, they usually say no, they're not small adults, and they will show how big a back valve mask is for like small kids versus adults, and you can see the size and doses. Of course, that's different, but like, and then there's the other way around where you have so much anxiety to actually treat the children because you're afraid to do something wrong. I've been to a lecture with Simon Carley once at the DEMS, where he usually, like, his point was they are small adults. You can definitely treat them. Just use an app to check out the dosages, like the Copy app from Rigshospitalet. It's a great 10 crowners, like one of the best apps on children, I think. And now they updated the Danish version so that you can have all treatments for children in it as well. So it's, yeah. So but don't be afraid to treat children. And I think I'd rather err on the side of kids are small adults, though they have special needs, and there's definitely special age-related things that you need to take care of as long as well as communication and pain management and so on and so forth. But for emergencies, I think really we should not be afraid of treating them. Just remember the dosages and a few other stuff if you remember communication and so on. But all right, so the sausage perios is the fourth point. So the analogy they made in the course I think was great, because an adult bone is much more like a falukorv, like it's quite dense in the middle, but and it has a soft skin. The perios is quite soft. The child is more like a salsicha. It's a thick skin, and well, it might be a bit softer in the middle. So when a child's bone is breaking, or a force is applied to a child's bone, it'll have these non-complete or incomplete breaks usually. And there's a couple we'll talk about. And actually they're on the same kind of spectrum depending on how much force you're putting on them. So if you have if you have force being put on a child's bone, then you can have what you call a plastic deformity, where you have or a pilbågs deformitet. They'll look like this, and they might be quite hard to catch sometimes, because if you don't know how a normal bone looks, and I definitely haven't looked at that many X-rays of children, then you can miss these, and these are important to catch, because they might be first of all, they might need operations. Second of all, remember, a lot of these areas where they might occur are in areas where it's vaniljekrans, where it's a circle, right? So this is one of those that might have Galicia fractures, or they might have some of these Montechias, or something like that, right? So we'll need to take care of that. Then if it keeps breaking, then you might develop a green stick fracture, right? Where it breaks on one side, but not the other, and that's because the strong perios is keeping it from breaking on that side. And then you have what you call a torus fracture as well. That's a compression fracture where it like bulges out, and you'll see these like breaks here. You see a little bulge, torus, or a buckle fracture as well. And these are usually you don't have to do anything for these other than information that they need a cast, I think, for maybe 2 or 3 weeks, and then the parents can just take it off by themselves. So these are quite easy to and forgivable to manage. this is also an example of the diaphysis is not magical, right? So they usually, if it breaks here, then usually they need some kind of treatment, reconstruction or reduction, operative reduction or something like that. Not necessarily these, but like as we talked about in the forearm, generally these need some kind of. We do not allow any amount of shortening of the hands because or the forearm, because then the hands will be in trouble if one bone is shorter than the other. Okay. Okay, and on to the fifth point. Kids are all or just small adults, but non-accidental injuries. I think we all have seen patients with non-accidental injuries, or at least suspected it. If not in a child, then at least in the adult caring for the child. So at our department, which mainly takes care of adults, I do a couple of these, maybe a month, maybe a bit more on certain months, because of adults mentioning that they have children, or I can see that they had children through their chart, and they come in with some kind of problem that is concerning for the or I'm concerned that the child may not thrive in that environment. It's important to make sure that where you're coming from when you're talking to patients and parents about this, that it's not it's a clinical suspicion, right? It's not that you're saying that they're necessarily bad parents. It's not that you're saying that necessarily this is something that is non-accidental, that they have caused it or caused harm to the child, but it's a suspicion like everything else in the clinic, and it's something that we really have to take responsibility for. And even though sometimes patients can become really angry about this, it's really important that we do live up to our responsibility for the children out there. Personally, I've worked in both pediatrics emergency departments and psychiatric emergency departments, and like also in children's psychiatry a little bit. So when you see children not having the help that they need, it's really important that we as a system can help them. And it's important to see that, to know that these the structures of most of the Scandinavian systems, at least what I'm aware of in Denmark and Sweden, we are a puzzle piece in this. So like the child social care services, they get information from both from us and from schools and from dentists and from like all these kinds of, like we were part of this bigger matrix that and we cannot look into like the amount of information that has been given. So we need to, like, every time we suspect someone, even though we think that this might have been said already, it might have been registered already. We don't know that, so it's important to at any opportunity that where we have a clinical suspicion, we should do this. As important that we as doctors we only have the need to have a clinical suspicion, as opposed to like everyone else who is not like enforced to do this. We are enforced to do this if we have a clinical suspicion of a child in risk of harm. And the way it's classically told, it's like there is physical abuse and there's psychological abuse, and it can be active or passive, right? So active physical abuse, that's hitting your child, right? Active passive abuse would be what you would call neglect, right? You would not give the child the support that they need, for, like food or shelter or whatever, clothing. The psychological active abuse would be being a bully, like horrible stuff to do to a child, like systematically, but systematically being bullying your children in a way that causes them psychological harm. And the passive one would be like also psychological neglect, not caring for them, not being there emotionally or supporting them, and so on. And I remember in that's the classical, like, kind of, and I might have the examples might not have been totally perfect, but that's usually the way that's classically been taught. But what I'm also there's a lot of gray areas, and this is really culturally different. This and as an example, I could say that working in the emergency department in Sweden, I've often been, at least in the capital of Sweden here, I've been asked by nurses, or I've been hinted at by nurses to maybe you should do a report on this, or you should call social services when a child, like when maybe a 17-year-old child has come in drunk, and maybe a bit more drunk than usual. And it's not been a systematic issue. The parent is there, and we do a talk and so on. But some of our nurses would still say that we should call social services, or at least notice social services with this. And personally, and this might be my bias from my background in Denmark, but and from a smaller city, but usually I would say that that's probably not necessary if the parent is there, if there is if there's no like red flags of psychological problems in the family, or when I'm talking with a parent, or when I'm talking with a child, there's any like risks or red flags coming up. I think, but and many of my colleagues will agree with me, I know, when I've discussed this, but some may not, and the nurses some nurses certainly don't. So there's culturally, both regionally and culturally, differences in these gray areas when we are saying that this is a something that has to be talked about to the social services. Yeah. Another example is when I worked in pediatrics. You have stuff like Munchausen and the Munchausen by proxy spectrum, and some theories or some hypotheses of this peculiar syndrome or condition or phenomena is that it's some kind of anxiety it's an anxiety disorder in the parents, that they don't feel like that they superimpose on their children, so that they may be health anxious, and they feel like, oh, my child is not being examined well enough, so like the strange bizarre logic of that would be to injure them so that they can see that there's something wrong, so they can be perfect, so they can be thoroughly examined, because there must be something wrong. That's the extreme, and that's I think it's a hypothesis, and it's not necessarily the main hypothesis, but it leads me to talk about the and the other end of the spectrum is if a parent is coming in with a child constantly or oftentimes, right, then there might be and there's nothing wrong, and the child has been examined every time, and it's sensible that there's nothing wrong with this child, but they keep coming back to emergency departments or other doctors, and that's kind of that's also, at least in where I worked in Denmark, that was also something that we would consider calling social services for, or calling that a something that we need to report to social services, right? Because that's kind of a failure to thrive thing for the child as well, like posing these kind of examinations on the child, always thinking that they're sick, like extrapolating the hypochondria of the somatization or anxiety, health anxiety of the parent on the child. Yeah. But again, gray areas. It might be a child, as we had a case, like it might be a child with where the parents don't want to give them their inhaler because they don't feel they are asthmatic and they live in different families. So the mother would give the inhaler and the other family would not give the inhaler. Or there are gray areas in this. And if it was a severe asthma, then of course, but it was a mild asthma, then maybe not. Depends on where it's coming from, right? Is it because of the concern of the child giving asthma medication, getting too much medication? Well, then maybe that's a good concern as well. So there are gray areas in this, right? A last example would be in where I worked. We had we often talked about if a patient was obese, like a child was obese, and the parents did not, like, after frequent tries to change the behavior, they did not do that, and we had a hunch that it was not being done, like they didn't invest in it. Then we would also, because like illness or obesity or leads to so much illness further on. So and a lot of these families don't have resources. It's not because they're evil or bad or anything. Like and everyone can fall into these, or maybe not everyone, but we are all prone to this depending on the situation, right? So it's not just the patients with marginalized patients. It's also someone who quote unquote looks good or looks nice and were treated us nicely and so on. So yeah, and other areas where we might think of it as adults, it might be, well, what about if the parent is severely sick? Would you just give a cancer diagnosis to a patient with two small children? Well, that's definitely going to be a failure to thrive thing for the children. Doesn't mean that they, like, when you report these things, it doesn't mean that the children has to be taken away at all. It just needs, it's just like a notice for the social services that these children may be in more need in the coming time than others, right? And then it's up for the social services to decide what kind of need they need and what they need. But that's the more broader introduction to this topic, and there's lots of more skilled and and well-read people on this topic that can talk a lot more about it. So, but the specific but going into the more specific non-accidental injuries, like more injuries that we think have a clinical suspicion that they are not just a trauma from exposure, but it's a inflicted trauma by someone near to the patient, right? So how would we suspect this in the orthopedic emergency department? Well, one of the most important things, I think, is the incongruency or discrepancy between the history and the severity of the injury, or not necessarily the severity of the injury, but if it's a really, really rare injury that they get, right, and the history just doesn't fit, like either because of the mechanics or because they presented late or they don't have a good explanation for something, or they weren't there, so on and so forth, right? We'll see what like the more common injuries are and what kind of injury patterns they usually have in the next couple of slides. And if it doesn't really match, then you should have some kind of suspicion, right? Be aware that when you're new, you might not have the gestalt to know what is common and what is uncommon, and that this might be difficult. But then you have to talk with one of your seniors if you have the suspicion, right? Other things like on history that might take us off would be parents' stories differ or change during the visit. And none of these are highly specific. And none of them are highly sensitive, right? But it's something that we should, like, they're all data points. There might be, like, for each of these, there might be a good explanation for why the parents might change their story. It might be perfectly normal, but if there are several of them, or if it's really, or if there's a pattern from previous, or if the child, like, also looks unkempt, in bad clothing, in summer clothing during the winter, or they, like, so on, so all of these are data points, right, as any other tests. All right, if they have serious injuries with delayed visit from the time of injury, right, so they come 2 days after with a obviously broken forearm. Why is that? With no good explanation. Like, it's not winter. They don't live far away. It's not like they couldn't give any child support, or child babysitters, or so on. So we had one place I worked in Denmark at one time. We did have a patient who was on summer vacation at our place, and the family, like, the injury supposedly had happened just before they went away, and now they were on vacation, and now they came in. It's like, why did you first came in 3 or 4 days after the injury might have happened? Like, it probably had happened. And then, well, that's the red flag right there, right? Because it was quite obvious what kind of injury the child had. So yeah. Then also, if they kind of neglect or kind of explain, if they explain the bad injuries with oh, it must have been a pet, or it must have been a sibling, or the child must have caused it. Like, they don't have a really good explanation for it, and they might, yeah, that's also a red flag. All of these, like, there's literature behind a lot of these, and let's go on here. So this there's the step parent, and that's more like, so every parent, I'm a parent as well, right? And every parent know that it's really tough having children, and if you really don't have, like, they scream, especially when they're really little, really small. They scream, and you don't get any sleep. And if you're someone coming into that family, I'm not saying that all step parents are bad or anything, but if you're coming into this environment, you're not as invested always, and you might be getting a lot of, like, the sleep deprivation and all the bad stuff, even though it's not your children. Like, and so certain groups may be more prone to then not having that attachment to the child, and then acting out instead of holding back, right? And and again, don't rule out the sweet and well-dressed parents. It can be anyone, these things, right? And again, me being a parent myself, I mean, like, there are times where you, like, middle of the night, you haven't slept for weeks, and the child is sick, or you don't know why they're screaming, and you can't, like, in these situations, it's really important. Like, this, like, the energy of a family is really important. It's like, how can you get more energy? Because the child, like, usually children do scream, and sometimes they scream a lot, and it's really important to, how can we get more energy into the system? Well, how can you sleep apart from, like, or sometimes you have to sleep apart from, like, don't share beds, so that one gets to sleep or get energy, or have resources so that you can be helped, or get work a little less, or, like, there's lots of ways, right? But if you don't take those steps, then you might more and more often come into these situations where you're just totally drained, and you don't have energy to, and when they keep screaming at you and you don't know what, then it's not far to, like, when you've been in those situations, it's not far fetched to see how someone in that situation could, like, hit the child or do something just to shut the child up, right? So again, just to say that this is not evil. Usually, like there certainly are some terrible, tragic cases of like pure evil, but like this is mostly not evil. It's more like lack of resources, marginalization sometimes, um, and lack of information about stuff about children and so on. So, all right. So the exam, right? So these were more history points, and these are like there's a long list of these, right? So, but these are just some of the ones that I picked up through the studies and through my time and experience and so on. So please don't take this as a review, more so or less a narrative review, I would say. All right, so the exams. There are certain specific points, like if you have burns in younger than 5 year olds, especially if they have the shape of an object like a buckle, like if they've been hit or they've been burn marked, if they have cigarette burns, if they have circumferential burns, like they've been submersed in something. And that might even have been, it doesn't have to be in boiling water, but it could be really hot water where you're not mindful that it's really hot. And like usually when you test the water temperature, you'll test it with water temperature before you put your child in, right? And if you don't do that, then maybe there's something like there's something that you need support with, like the parenting style or the parent, like being more aware of these like dangers and so on. So it doesn't mean that doesn't mean that you're a bad parent, but it means that you might need some help or might need some instructions, so on and so forth, right? So, because usually you would check the temperature before putting your child into a hot bath, right? And then there's like, or maybe sometimes it's a bit too hot. I'm not saying you should be anxious about all these things, but in general, like for them to be burned and then just to keep them in, there's like there's a magnitude of difference, right? How hot it has to be before that you can do that. All right. So there's some certain location-specific injuries like mouth, tongue, teeth, jaw, ears, neck, cheek, and butt cheeks. And I'll have a diagram following this, but there's certain locations that are really highly specific for these. Then bruises under 4 months. You usually say like those who don't bruise don't cruise. Oh, sorry, those who don't cruise don't bruise. Like if they're not walking, then they shouldn't bruise. At least not in like a lot. And there are certain areas that are like they should not bruise in. And then yeah, injuries with an object shape, not just burn injuries, but also if they've been hit by a belt buckle or something like that, or yeah, it had the hand mark on the cheek. Yeah. Then the X-ray, like radiologists are often taught about these specific ones, especially if you're working on a child emergency service. But if you're working in an adult emergency service where they sometimes see children, then they might not. So maybe you have to be be aware of these. So there's there's a list here you can read it yourself, but there's a longer list than this as well. But there are certain fractures that are and these depend also on like the fractures that they get depends somewhat on. Again, there's a mechanism here as well, like shaken baby. That's also a mechanism. That's because well the child the neonates or the younger children can, like the really young children, newborns, cannot hold their neck, and then when you shake them, then that's why they get the shaken baby, like the bleeds in their heads. And in the same way, when they grow older, the children, you will hold them differently when you have to shake them or have to like hold them. So, and I cannot remember the details of this because it's been some time since. But it's like when you hold them on the thorax, then they have to be a certain and they get rib fractures, and you have to be a certain age. And once they get a bit bigger, you have to hold them like on the shaft of the humerus, and then they get those kind of fractures, and so on and so forth. So there are certain mechanisms that go along with a lot of these. Yeah. Then what to do? Well, if you have this suspicion, if it's really like it's a really dangerous thing. I'm not, now we're not talking about the you only have the parent and you were suspicious of the child having something. Now it's like you have the child in front of you that where you have a high suspicion. Then you should really consider admitting the child with the parent. That would be all right. But if it's the same parent that might be doing this, then it has to be under surveillance, right? And it's important here in Sweden, they just passed a new law. Well, talking about cultures, right? Differences, but they've just passed a new law here. I think it's about half a year ago, um, or sorry, a year ago, where where it's now considered also an offense or something that we have to report if it comes to our attention that the children are being if there's if the children are witnesses to violence, so that like if the dad is hitting the mom or the mom is hitting the dad, or there's any violence, systematic violence at home, right? Then we have to call child services as well. So that's the same as if the child is being hit. And I think that's sensible. That's really sensible, and a lot of us have been doing that for some time anyway. I'm not sure how the laws are in Denmark currently about these things, but I think that's a sensible law. Then you have to take a detailed history, right? You have to take pictures as well of the injuries, and then depending on your department, this might be done vastly differently. I've been working in several places where it's done with a camera and a chip, and then you put the chip in a document, and then you send the document, and it's really like high risk of this being delayed or missed. And in other cases, where we currently work, we have an iPad where we put it into the system directly almost. But it's usually a process this, and it's really important that you do a decent history and a decent examination, like really like describe the wounds and what kind of like how like objectively describe them, how far, so that you can picture it, right? So that it can be read in a courtroom, because that's what it is sometimes. Then, and this is not something that we usually have to do right now, but you usually do an X-ray of the entire child during the workup. Where I've worked, we usually admit these patients to a socially like the pediatric departments I've worked at usually have a social or socially engaged doctor who takes care of these things, or there's like a part of the department where they take care of these children, because it's sadly not uncommon. I think some studies say like maybe 5 or 10% of all children has some kind of abuse in their background, right? So, but you have to do an X-ray of the entire child, right? To see if there's any other fractures missing, or if there's like also to add up some evidence as well, if there's different fractures and different healing stages and so on. And then you have to work up if there might be other reason to these common, like a lot of fractures in the patient. That might be osteogenesis imperfecta. In Sweden, there's a register of this, and you usually call this register, and then they can tell you whether or not this patient is part of that register. And then there's certain other conditions, metabolic errors, inborn metabolic errors, and so on and so forth, depending on what kind of injury it is. That's usually more the shaken baby syndrome, I think. And usually you have to do an eye exam as well. So there's a workup to see if there's any of the rare conditions that might be the cause of this. Then you contact your social services. Here where I work currently, this works. It depends. Like just as an example, it depends on what kind of region of Stockholm the patient is coming from, right? So if it's a marginalized patient coming from a marginalized municipality, then it's usually a problem, and we usually fax these things to these areas. So it's a lot of work to get to actually get a hold of these, and usually the best way to do this is just to wait until after 4. Then the social, then the common like the common whore, the common like the doctor who has a shift, a social shift. They come and work out of hours, and that's more easy to just call them. Yeah. So if it's really problematic, then you also call the police. And I remember in Denmark, I think you should call the police. Was the routine 114? So like no matter what, like you have to know what you do in your department, because it differs depending on the country and sometimes depending on the region. And then you have to you have to know whether this is something that has to be taken care of urgently. Like you have the child right now in front of you, and they might have siblings at home as well, so they might also have to be taken care of. So that's an urgent case, right? If it's something, they might be in danger as well, potentially. But if it's a parent, you haven't seen the child, then there might not be as much. That may not be as urgent. Maybe the parent has moved away according to the charts from the children, but it still has to be like said and talked about to the social service. And sometimes you don't have to call them; you can just fax them and so on and so forth, right? So there's different amounts of urgency, but the most urgent cases where you have to admit a child, you always need to know: do they have siblings? Do we need to take care of the siblings as well, and so on and so forth, right? And then you have to inform the parents, or at least you have to inform the parents if it doesn't affect, you don't think it affects the child makes any other children or the child which is your patient getting to harm's way. We should always it's almost always always we should try to inform the parents, right? And I talked about the mindset of how to do this. I think it's important to say that I have a suspicion of something. The reason why I have to do this is because I have a suspicion from what I've gathered from the data. It doesn't really fit to me, and I might and just you can play stupid yourself, right? I might be wrong. I hope I'm wrong, and if I'm wrong, then this is we are doing this to make sure that your child is safe in these environments, right? And I'll rather be wrong 1,000 times than be than miss one child who's actually being abused, right? So there's certainly it takes skill to inform the parents in a way, but usually they it's an inconvenience, but usually they understand. And if and remember, sometimes the parent that are with the child doesn't necessarily know about this, right? It might be the other parent or step parent or so on and so forth that might be the inducer or something else, right? So but I always try to inform the parents and not try to make it up like they're evil or bad parents, because usually they're not. But they might be needing resources so that the child can thrive, right? That's like we both want the child to be as safe as possible in the same environment that they're in right now. And if that's not possible, then yes, in the really rare cases, then the child has to be taken away. But that's really uncommon, and it's something that they strive for, the social services usually, because it's really beneficial for the child to be raised by their biological parents, if that is safe and if it can be achieved, right? But especially that you're not necessarily bad parents. This is something to do with lack of resources, or we need to they might need some help or might need some support, and then you can get back to a stable place, right? And I'm a I have a high achieving job. I'm not I don't live close by my own family. I can relate to how hard a lot of these things can be, but when you have small children, and how tough it can be, especially if you don't know the system, or you don't know the language, or you come from a different culture. I get it. So I think you have to come from a kind of empathetic way, but also make sure it's not a good thing to do. If this is right, then it's not a good thing. You're not normalizing the behavior. You're just saying that you get where it's coming from, and you need support to get rid of that kind of behavior, right? Or to stabilize it. All right. I think I got the point across, right? We talked about like we are only one puzzle piece. There are lots of other services that connect to all of the connect to the social services, and they get input from all of these places. So our input is one just one piece, but if they get same input from a lot of places, then they will urgently react, I think, or then they will really take this case much more seriously, right? So for them, they get data points, and we have one data point, and the others have other data points. And then if they have gathered like systematically problematic data points over some time, then definitely then it's really high yield information for them to do something. And we talked about like the mindset towards the parents, and this is me talking on, and this is what I've gathered from my experience, but and some might disagree, and please comment if you have other ways of doing this, but I think the non-judgmental way, and just like you're doing your job, and the reason why you're doing it is because you want the best for the child, and that's something that you can get. I'm sure that the parents can get behind as well, right? So we're all doing this the best for the child, so that they can thrive. That's like the most important thing. We talked about there might be gray areas. Some might think like alcohol, obesity, or and so on, or some like what you would call anti-fragility behavior, like the parents were just leaving their kids on the playground, and like, oh, is that, some might be, oh, that's dangerous. But if you read like Jonathan Haidt and anti-fragility, and if you read I think the book is called Free Range Kids. About like leaving your kids on the subway in New York, but you have taught them, you incrementally taught them this skill, and it might seem to a stranger like this is terrible parenting, but actually it might be, I would think, just the opposite, like making them more comfortable with the world, so that exposing them to the world, so that they actually know how to deal with it once they grow up, and are not just thrown out into the world without any exposure when they turn 18. So but some behavior might seem dangerous to some parents, and others, again, just be aware that there is cultural differences, right? Another example from Stockholm, like making your child like riding a electric scooter with your child without a helmet, like that's something that for me borderlines to something that it should be reported, right? So, but that's culturally accepted currently in Stockholm, or somewhat at least. So again, there are gray areas, and it's up to you again, and the social services, because if that single incident, well, okay, they ride on the scooter without a helmet, okay, that's pretty normal. It's a bad thing to do, I think, but probably it's if they come in several times, like 5 or 10 times during the year, or maybe less, but several times with fractures each time, then yes, then it's probably something that you should do something about. Or if they've gathered other puzzle pieces from other areas of the system, then yeah, then that might be something that you should they should react on, right? But so it's not as much always about like in the non-obvious cases. It's not as much about the one event. It's more about the pattern. And if they're good parents in all other situations, or they're more, then it's probably not a problem, right? And then, well, who am I to decide how do they do this, as long as they're not dangerous to others, and as long as the child is thriving and they actually yeah. So I think you get it. And we talked about what kind of like my old definitions of this. I think they might have been updated as well, like the physical active and psychological active and passive. And we talked about the witnessing domestic violence is also a new law in Sweden here in 2021. That's like the same as being hit would be witnessing domestic violence. Okay. And here was this somewhat famous Maguire diagram. This is a good article as well to check out if you are interested in this. And you saw the link before from Don't Forget the Bubbles. They have several links as well on this. So here were some of the normal accidental bruising patterns on children. Like they have this T shape here and they have the back of the head. Like how would they usually walk around and hit themselves? Well, they hit their knees and they hit their, but if like these are uncommon areas somewhat. Again, this is data points. They might, if they have a really good story for it or they come right away and there's like nothing else red flaggish about it, then maybe it's all right, right? So, and I guess I'm sure if you read into the literature, there are some of these areas that are really high, like this should not happen. This is a high signal, no matter what the story is. And some of them might be, oh, maybe sometimes it's seen, sometimes it's not. So I don't know about the percentile and the risk of these, but this is a common diagram, and I'm sure that other experts would be able to say much more about this, right? So, all right, so let's go away from the non-accidental injury topic and then move into the more specific kinds of fractures. And before we go into the entire fracture encyclopedia here, I'll just quickly mention some epidemiological like facts or studies, just to get an overview of what kind of fractures children actually get. If like we talked about like this cookbook that all departments have a cookbook, right? All emergency departments that I've worked in with an orthopedic service have a cookbook where you look at the fracture kind and then what kind of fracture this, and then you'll see the treatment and so on. And like scaphoid fracture, well, 7 to 10 days in a cast, and then you have to send them to MRI or so on and so forth, depending on local guidelines, right? We all know these, but there's a good one for children called Barnfrakturboken, Barnfrakturboken, from Astrid Lindgren's Barnfraktur Compendium. Astrid Lindgren's, for those of you who don't know, is this child hospital in Stockholm. In Karolinska, in the Karolinska complex, and they have this book where they have not only the treatments but also like some background information. It's really good, and it's like it's really good to just. I think a lot of Sweden actually uses this when they treat children. So please look at that if you're interested in the more detailed treatments, right? Okay, so epidemiologically, I'll be using a lot of facts from Hitstrom 2010, but I'll also mention just randomly cherry picked a few articles, just to get you a sense of the landscape of fractures in children. Okay, so around 1/3 of children will have a fracture, according to the study, during their lifetime, as a child, of course, and this study is an epidemiological fracture study of children in Umeå, and it's important to know that this is a skiing area and ice hockey area in the northern part of Sweden. University hospital it is, and from this period of time, this retrospective chart review, and from their study here, they saw that the amount of fractures actually increased from 500 to around 800 per year, what they saw in children. And they suspect that it's because of children being more active. It might also be, I could suspect, that the sports that they're playing are more risk prone, or there might be like more trampolines. So there might be, and there are definitely seasonal, like there are these seasonal factors, there are cultural factors, like some places have skiing resorts, some places don't. Some places have riding facilities, some places don't. There are, and then there's like the 1.5 male to female ratio. A lot of this is also like males usually get into more traffic accidents, at least when they come into adolescence. They might be more fighting more and so on. So certain fractures are more prone for males than females. Not saying that if you're a male, you will get this, but it's more like on a population level, the kind of thing. Okay. So, and another thing is like it really like as with everything with children, it depends really like the differentials really depends on the ages. Like what kind of disease they get is vastly different from a 3-year-old, depending on from a 12-year-old usually. And the older they get, the more adult-like they get. Right. So um, traffic accidents increase with age. No, no surprise there. Collisions also increase with age. Or struck by other persons or physical objects or animals. Crushes are kind of the same, but the big one is like the falls from planes, like more and also as opposed to from your own height, than the falls from planes. Like from own height is quite stable, but fall from planes like high buildings or more than 0.5 meters, as defined as, they fall drastically from when you're a toddler and down until you're around prepubescent teenager. Okay. Um, and downhill falls like for skiing or sledding or something increases with age around until here, and then it's and this was just one study. Again, a study in another region might be different, but I'm trying to give you like just a bit of cherry pick, just some literature on this. The kind of sports here in this Swedish study was like soccer, and that's really prevalent, of course. So that's not a big surprise. Riding is more prevalent with girls, and then snowboarding, ice hockey, and downhill skiing is quite prominent, right? And you have your normal indoor like floorball, gymnastics, basketball, and so on. All right. So doing activities are generally dangerous, or if you think of them in fracture terms. But I would argue that the benefits vastly outweigh the risks, at least with a lot of sports. Certain sports have certain mechanisms, like ice hockey might get these clavicle fractures because when they bump into these the fence or the borders and so on. Like each kind of like snowboarders fracture is called that for a reason. Soccer often have clavicle fractures and so on. So like each has a specific mechanism, right? Then on to like what are the most common fractures, and in this they did like a small overview of in all the studies on epidemiological data from children. What are the most common fractures over all age groups, right? So it's really like we don't actually want to know what kind of like over all age groups. We want to know what in our age group that the patient that we have in front of us. But in all age groups, like distal forearm fractures is almost always the most common. I'll give you, but these are all Western, so I'll give you some examples from Eastern literature. So here we have the like top a bit more than 10. So again, distal forearm fractures in this Swedish study from northern part of Sweden, a skiing resort area, and then not skiing resort but skiing culture area, an ice hockey area, and clavicle fractures. I guess that might be ice hockey as well. Um, and then fingers, ankles, toes, and then you have like a lot of them, 3 to 5%, right? And just to cherry pick another study, again cherry picking, not a systematic review of this, but just to cherry pick another study from Ireland. Again, this was also the distal forearm. This is the buccal fractures. Here, the distal humerus, which was let's see, down here 5%, it was all the way up here to 17% here in this study. So there's regional differences here, right? But and the angle, but the rest is kind of the same, like maybe with a few percentage off, and also the registering is a bit different, right? You have scaphoid here as their own thing. So, but overall, it seems kind of the same. This is also a Western country, but it's not a skiing area. It might have other sports that are important there. So, and here we have like an outlier or a bit different at least. So, Kui Shenzhen, China, from 2022, they have a distal humerus fracture, which It was common here, like the cervical, but it's really uncommon here, as they're most common. And then they have like their distal forearm, no surprise there. But then they have fingers. And then they have like the angle is a bit hard to find in this study because it's a combination of different specific fractures. But it's not that different, but there's certainly like some spread, and whether it's the study method or it's the regional differences and so on, it might be like I think it's a mixture of like what mechanisms, what culture, what kind of sports, what kind of situation and context they're in. But it's surprisingly like a lot of these fractures that are quite common in the West, are like toes and clavicle and metacarpal, are not that common in this study in this region. Okay. Just to show that there are definitely different fractures depending on the age. And this is from the Irish one, the Bake review here, the Bake study. And like when you're a toddler and when you are a bit more than a toddler, like a preschooler, then these buccal, like the distal distal radius fractures, the buccal fractures, are really common, and also these distal humerus fractures, suprachondral fractures, which are really important because they might have a radial nerve or artery problems, right? So they're really important to know about. These are quite common in this age group. Okay, and but then as you grow older, um, in this study, angle fractures become more common. Metacarpal fractures, maybe from hitting, become more. So just really like it seems like there, yeah, the injury patterns are different depending on the age, right? I guess that's the take home here. Just to show, like this is from the Chinese study, and they kind of show the same thing. Like certain fractures go up, like with time, and other fractures go down with time. Also, like it changes with age, and you can pause to study this as well. I think it's quite a messy picture, so, but you can just check it out by yourself. All right, so moving on to the specific fractures. So clavicle fractures. This is is usually a clinical diagnosis actually in children. Remember, we're trying to reduce the X-ray amount, even because, as we know, the risk for children to develop something along a long lifetime in currently growing tissue is much larger than for an elderly lady. So we should be much more conservative with our X-rays. All right, but this is usually a clinical diagnosis. As we saw, it was one of the more common fractures. The treatment is conservative. It's almost never, I think never actually, operation. It's usually a collar and cuff for pain. And if there's no pain, then they can just go nuts. They don't have to have that. And then they usually it will be painful for 2 weeks. So treat the pain. There's a great children's pain guideline on Danish Pediatric Society's homepage. But also, when the patient, we haven't talked about when the child is in pain right now, and you have to suture, or you have to do something. Then usually, like, besides all the non-pharmacological stuff, that like sit with the parent, try to distract the patient, explain what you're going to do, and do it usually quite fast, like rip the band-aid off faster. There are different philosophies on that. There's a great stimulus podcast on how to do that, talking with the child and doing that. And then distracting the child with an iPad, and if it's a small child, give them sugar, or like nursing them before, and so on and so forth, right? All the great non-pharmacological, really important non-pharmacological pieces of advice. Besides that, you have to choose how to actually, when you have a screaming child, you need to like examine him. You have to, and they have to warm up to you, of course, but you really need to do something right now. You've optimized all the non-pharmacological stuff. what can you do then? Well, some use like sedation, like knocks, um, and then there's some like gas anesthesia, light gas anesthetics, and that might be a good idea sometimes, depending on your department, right? I found it quite useful when I've used it with children. You might use ketamine, or sometimes used in especially in America. It's quite safe, but it has to be like locally endorsed. A lot of areas used latte yield as well. And we sometimes use intranasal morphine, intranasal fentanyl, which is also really good. At least if you're doing it right. And I've done a previous video on airway where I go through how to do that right. So just to sum up, like pain with children is good to have a plan A and B and how to manage the pain. All right, back to the clavicle fracture. So it's important to say that to the parents that they'll get the child will get a bump, like up here, cosmetic bump, in 6 weeks, and you don't have to do anything about it. It's something that they will live with. All right, then the humerus fractures. You have the proximal humerus fractures. They were somewhat uncommon, almost always conservative treatment, but with big angulations. It has to be really big angulations. Then they might treat it differently, but in general, because of the metaphysis, usually don't have to do that much. It can be treated conservatively. The diaphysis is not magical at all, so you have to have operation if it's ankulated and a cast if it's non-dislocated usually. Then you have a supracondylar, and these were really, really common, right? As we saw in almost all of the studies. And here it was really, really important to remember like neurovascular. And here was this tip of like if they have compromised, like this is a simple way, but like some of our lecturers, like one of the lecturers in our course used this rule. If they have capillary refill time, that is good, but they don't necessarily have any pulse, then it's like you can usually wait. You'll call your consultant, but they can usually wait for the next day. If they don't have capillary refill time and they don't have any pulse, then it's now. Then there's like arterial compromise. But if they have both, then it's operated on within days. Also, when we went through like all of the tips for looking at elbow X-rays, that can be quite tough, especially with the even in the adult, but also especially in the child, because they have all of these ossification centers. All right, moving on. Humeral condyle fractures. Whether or not they're operated on depends on their amount of dislocation. And the same with the older ones, right? Then you have your column radius. If very ungulated, operate. Always think that there's it's a broken chain, right? There might be a break anywhere else or a subluxation somewhere else that needs to be dealt with. If you have forearm fractures, again, everything on the forearm, often that is not metaphysis, usually has to be operated on. Think of you have the Montagia and you have Galicia, which are somewhat child fractures. You have diaphysis and ulnar fractures, especially with this plastic deformities. And if it's big, then you have to operate. And also complete fracture. Like in general, like you don't accept that much of the shaft fractures to be. They often are operated on. Unless they're really uncomplicated, or if they're like as opposed to the metaphysis fractures. Okay, distal forearm fractures. This was the most common, right? And usually, like if it's a green stick, then it's casted 3 to 4 weeks, and then control in 1 week, see if it's healing. If it's a torus fracture, then usually it's like give the cast 3 weeks, no follow up. The parents can remove the cast themselves. And then there's this kind of fracture, and this little tip to how to fix it. The basis of the proximal phalanx, that's like this was one of the common fractures as well, the phalanges fractures. And depending on what kind of phalange it is, it's usually like a little bit different treatment. Sometimes there's like subluxation or luxation, and then you can fix that by putting a pen into the room between the fingers, and then just push on the top of that finger. So you push here, and you have this lever with a pen here, like shown in the picture. Okay. Femur fractures. It depends on the age, yeah, and they're in certain studies. They were in the Chinese study. It was not that rare. It's rarer. It's on the rarer side, but it was like top 15. All these and this list I'm going through now, by the way, it's not necessarily like children can get scaphoid fractures. Children can get a lot of the fractures that we have talked about in adults. Not the geriatric ones though, like not hip fractures. That's uncommon, but they can get like these are more like these are the fractures that you usually see or you need to know about for children that are a bit different than adults. That's kind of my method for this list. All right, knee. We talked about if you have a swollen knee with a child, like a traumatic swollen knee, or you had a patella lux with a swollen knee, you need to like either just order an MRI within 5 to 10 days because it might be an imminentia fracture or a collar fracture, or if you want to like be more specific right away, you have to put a needle into the joint to see if there's blood. If there's blood, then you need to order the MRI. If it's not blood, it's just swelling. Well, then it's probably not necessarily to do the MRI, but it depends on local guidelines. And like if there's blood, then there's usually some kind of fracture, right? If there's a lot of blood, and especially if there are fatty pearls, then it's a fracture on very likely. All right. Then you have your proximal tibia fracture. These are not uncommon. It's like I think it's about like 1 or 2% in the study, so they're not common either, but they're seen. And these are usually 3 to 6 year olds, and it's also usually treated with casts. Then you have your lower leg fractures and your isolated tibia fracture. Again, that's usually a cast. Tibia and fibula. Well, you can almost read these, but I'll get down to these diaphysis fractures, right? But you have what you call a toddler's fracture, which is a fracture that usually occurs when the child begins to walk, like from 9 months usually, and then until 3 years of age. And it's quite easy to miss because it's usually just a small, like it's in if it's undislocated, and it's usually just a line through, and this line might be a bit hard to actually see. It's by definition a toddler's fracture is a non-displaced spiral fracture of the distal 2/3 of the tibia shaft, right? And the mechanism is usually quite trivial. It's a triple fall, but also usually with a twisting mechanism. And it's in the Acid-Lingan book. Usually the treatment depends, right? But it's become more and more conservative, the treatment. Like 3 to 4, because a lot of these are usually missed probably, and the children will just walk around on their fractures anyway. But used to be like maybe 3 weeks in a cast. Here they say around 2 weeks. And sometimes they don't even need a cast, our course directors said. And that's actually what the orthopedic one here from Esslingen also says. Like they can have a cast for 2 weeks, or maybe even be left without any kind of treatment. Depends on what the parents are up for. Like, and yeah, so that's the shared decision making. If it's going to be really hard to make the child stay still in the cast, then maybe the cast is a better choice. But it's if they can just make the child be a little less active for just a little like these 2 weeks, then it's probably better to leave without the casts. It depends, right? So it's shared decision making. Then you have the Tilo fracture. We talked about that. It was that sugar cube breaking away. Sometimes operation, but oftentimes it's conservative. It usually depends on the CT. That was a sugar cube and breaks away because that's not ossified yet. It ossifies from here to here, and then it becomes told. So after 15 years, then this won't be possible. And then we haven't talked about back pain or back fracture, but any back pain in a child is really uncommon, and it's a red flag in and of itself. All right. Then on to a common presentation I just wanted to go through, which is the limping child. There's lots of literature on this, and it's like a really common complaint in the pediatric emergency department. I've seen lots of these kids, and it's quite hard to work them up oftentimes, depending on their age, of course. But one tip is always examine the entire leg, even if they say that it's the hip that hurts, examine the entire leg. You have to rule out. There's a mnemonic that I don't use because I think it's not that useful. It's called Stop Limping. You can check it out here. But some of the ones that you have to rule out at least is Peds disease. If they have Peds disease, it's usually like this differential is also depending on the age. Like you don't have a 4-year-old with Peds disease, but you have prepubescent, usually males, I think, that have Peds disease, and it's really hard to find these. So if you don't find anything on the X-ray and you're not at high risk of any others, then you have to follow this limping child up and suspect this until proven otherwise. Then you have your this epiphysiolysis, or SCFE, slipped capital femoral epiphysis. Usually this was the prepubescent, usually male. That don't want to play football, and then they suddenly jump off a tree or fall off a horse or something like that. And then it hurts, and then you come into the emergency department. Then you have to do a special view called a frog leg view of the hip. And if it's negative and you don't don't suspect any of the others, because you might suspect that some of the others because it's a minor trauma usually, not necessarily something that they know about when they come in. Then you'll just send them home, but they have to arrange follow-up again to just see they should stop limping at some point, these children. If they don't, or if it gets worse, then they have to work them up more and take new pictures. And of course, you have to think about the infections, septic arthritis and osteomyelitis. And septic arthritis, especially with the younger kids, are usually something that is really hard. And something that is commonly suspected because of this is the coccygeal simplex in the hip, like a hip with a cold, we usually call it. It's really common, and the septic arthritis is the differential to that. And there are scores now to kind of differentiate between them, but it's hard. It's usually hard, and sometimes you have to observe them. And the other differentials are toddler's fracture. We talked about that before. Malignancy. And this is important because osteosarcoma or Ewing sarcoma might present like this. Usually, as we talked about, the pain is all through the day and worsens at night, as opposed to night pains, which are only at night and not on the day time. You have leukemia, which may present with like pain in the legs. Also always think of referred pain, right? Hip pain in the knees, right? Or knee pain, which actually refers from the hip. Always examine the entire leg. You have iliopsoas abscesses, which I think I've seen one of these as well. You have pyomyositis. You have neurological causes where it's not really like they're limping, but they're not limping because it hurts. They're limping because they don't have any muscle mass yet left, and they're like you can, and this can be subtle in children as well. Be like so, check the reflexes, check the neurological status as well when you have these children. And you have juvenile idiopathic arthritis as well. Usually they don't come in with limping, but they might have some limping as well, right? So it's on the differential as well. Also think of referred pain not only from the hip, but also think of it from the abdominal region. The appendix right here, right? So also, for male patients, that the testes are also important. Yeah, the most common is usually the coccygeal simplex. They just had a cold. Now they have a hard time moving their leg. They will usually be, if it's a lot of effusion, they will usually externally rotate their hip, so to make up space. And yeah, so but I won't go into these. I just wanted to, the limping child is really important. If you work with children, that's something that you're going to see a lot of. Make sure you know the differentials and how to work it up. The take-home points from don't forget the bubbles on this is consider the age, because the ages are different, right? Depending on the ages, the differential is different in all pediatrics depending on the age, but especially here as well. Most children are okay. They usually have like the cold hip or something that and they'll just go away. If they have fever, you always have to investigate, and that's why I say like the coccygeal simplex is really hard to differentiate from the septic arthritis a lot of times. Consider the referred pain as we talked about, and always ask for about systemic disease, right? Leukemia, but also like the more common systemic diseases are important to think of. Consider age. So we'll just go through some of the age, like how to consider age in these groups. So as we said, prepubescent, maybe a little bit younger than prepubescent, but cavalic perdis is usually something of, and the slipped capital femoral epiphyseus. These are usually prepubescent children and preschoolers. Some of them are any age, like trauma, neurological, and discitis are any age. The congenital is also any age. They can present depending on the penetrance of the neural muscular or also neurological disorders, but this is a different thing. The congenital hip, but they can present at any age. Tumors also any age, inflammatory and infection. So usually younger children. And then you have the sudden, like some of them are sudden. This might be, as we talked about, sudden. It might be a trauma, but it might not be as well. And that's the problem with this. It's really hard to find these sometimes. Trauma is always sudden, and the others are gradual, depending on how gradual they are. Over, like neurological, is usually weeks to months, right? Tumors are also weeks to months. Infection is usually days, right? So it depends. Fever, they might have an infection and in GIA, inflammation, and tumors sometimes as well, right? Pain on everyone except neurological and maybe the congenital dysplasia. And then swelling, yes, often there's swelling in these conditions. They will usually externally rotate their hip if that's where it is, but the others will not have swelling, right? And loss of range of motion, yes, because of the swelling oftentimes or pain, but not necessarily. But these usually will have. just to like these are the things that you have to think about and ask about with this patient group. Okay, moving away from the children and then moving on to geriatrics now. And this will be the last part of this lecture, right? So we talked about like all of this. Please go to emergency medicine cases and check out their geriatric trauma podcast. It's really great and gives some great tips. There are several books on geriatric emergency medicine as well that are really great, among others by Christian Nichols, the European book, and there's one by Amal Matsu and Peter Rosen in the United States as well on geriatric emergency. I really like that book because it's more narrative, and it's not just trauma. It's for all of geriatric emergency medicine. But this is one of the biggest groups that we see, so it's really important to know some of the things. And we've already talked about some of the things. I'll just highlight a few things. It's really important to know about the biological age for all the patient. Not just because of frailty scores, like Rockwood frailty scores and the prognosis for the patient, but also can this patient be operated on and can they be operated on if the operation goes wrong. That's usually what is part of the reason why patients are operated on or not. And how good are their ADL? These are information parts that are really, really important for orthopedic colleagues when we consult them. As we talked about, and I won't go through again, it's really important to work up all like quote unquote mechanical faults as if there's a cause of it. So we need to work up, especially like for like I see mechanical falls, as do a lot of geriatric experts. Mechanical fall just as delirium, just as any other geriatric decompensation, as the symptom of something underlying, right? And the workup is often kind of the same. In delirium, you also check for drugs like medications, new medications, and specifically anticholinergic medications, antihypertensive medications. There's this stop scores or stop lists. There is Beers lists. There's different lists where like there's the Danish seponeringslist and different lists where you need to go through the drug history. Check out if there's infection, and the more frail they are, the less stressor they need for them to decompensate, right? So someone who's maybe have dementia will, and the more severe dementia it is, it will be less and less that will make them decompensate, right? So it might be obstipation, it might be different work, also different living environment. All right, and the problem there is that they present the same way. Like it's almost like neonatal medicine. Like neonates have very few ways of expressing a lot of like vast amount of differential diagnosis, and the same goes with elderly. They might they fall from the smallest things if they really frail to the really big things like ACS, or it's really hard to pick apart because they can't tell you about whether or not they're hurting. So it's really more almost veterinarian medicine when it comes to neonates and very old frail patients. And we need to be really good at examining from top to toe there. Okay. Also, there's a little bit of more like highlights. Elderly patients who foosh usually have some kind of mental capacity left, right? They have the reflexes somewhat left. If they don't foosh, then it does say somewhat. And this, it might say somewhat that, well, they don't have the capacity to, or the speed, or the agility to actually do this anymore. They are quite frail in and of their own, because they cannot. It's important because they cannot foosh. They'll just fall on their bottom or fall on their back, as long as And you can also think of drugs like sedating drugs or alcohol if they do that, right? For frailty, it's also important to just check the chart, check the old charts, right? See if they've been in 2 or 3 times the last couple of months. Then definitely they're that's a red flag for high risk, high frailty. And even if they were much better 2 weeks ago or 2 months ago, when before this entire escapade of admissions were begun, then they're not the same anymore. They have been in hospital for 2 months almost, and they have not been rehabilitated in between. So when you're talking to their families, it's really important to like manage expectations about these things, even if it's a hip fracture, right? And there's a reason why it carries a high mortality. It's not necessarily because of the hip fracture. It's probably also because of the patients who get them are the ones who didn't foosh, and the ones who didn't, who were already admitted and might also might be so frail that they will decompensate when they get an UTI or something like that. So right. All right. I talked quickly in one of the lectures about the osteoporosis fractures. If they get any of these fractures, you might consider working them up for back fractures. I forgot back fractures here, but you might consider them working them up for osteoporosis, either when they're discharged or usually, well, usually when they're discharged, right? And I guess there's local guidelines depending on whether or not you should do this. I've never seen any strict reasons or strict rules for this, despite unless it's hip fractures in someone who was not osteoporotic before, or also back fractures, right? Vertebral fractures. Okay. We talked about the falls, mechanical versus secondary falls, like decompensation. It's also important to say like immobilization kills, right? You have to immobilize them right away. You have to really take it seriously when they have a fracture and they don't mobilize. And it doesn't have to be a serious fracture. It's like one example is the rib fractures, right? They really, really have to be in such a good, so well medicated for the pain so that they can breathe and so that they can mobilize, because there's a high mortality and morbidity associated with not being able to mobilize these elderly patients. So they really, really have to get that morphine or whatever it takes, right? Depending on the situation. Sometimes, yeah. And oftentimes we admit these patients because they have to be pain managed and they have to be mobilized and so on. And you have to arrange follow-up and the rehabilitation. It's really, but you have to make the pain score when they're mobilized and when they're lying still, because they have to have in both situations they should have to be, it has to be bearable, right? It has to be and not just bearable, they have to be treated so that they can actually move around. Also because there's a risk of delirium, right? Also if you overtreat, but mostly if you undertreat these patients, right? And remember Movicol, right? Remember Laxantia when you treat them, because that can be another, like there's a reason why this is so complex, right? There's a high morbidity and mortality in these. It's also because of the complications that they give because of iatrogenic harm, right? Because of obstipation, because of so on and so forth. So if you have an osteoporotic patient, then don't think so much about the high risk and low risk mechanisms, right? Because the low risk becomes high risk. They can get a cervical fracture, cervical spine fracture from falls from own height easily. They can get dense fractures and so on. So it's really important that osteoporotic fractures, and also like patients with DISH and morbus Bechterews, they should be working up aggressively if they have falls and they have clinical status that seems like it's a fracture. If you have someone where you actually need to do a CT of the head, depending on what in Scandinavia we usually use the Scandinavian trauma head score, and for some reason, I've never managed to figure out how the S100B is part of that, and the S100B, a lot of the places I've worked at, it wasn't part of the, like we couldn't take it, we couldn't use it, and now we delve into the literature. When I delve into the literature, like it's not used internationally for this purpose because it's really bad literature on it. So I'm very suspicious of why we've chosen to, like, why the neurosurgical society of I think it's like a Scandinavian society that's actually going out in the British Medical Journal with this article in, I think it's 2014, 15 maybe, and it's become a guideline all over, with this S100B as one of the cornerstones in this low risk population. It reeks a little bit, I think, and we're the only countries who use this in this way. So S100B, just to say, if they have an injury, if they have a significant wound injury, you cannot use it. You have to use your clinical gestalt. The patients are excluded in the studies if you have a wound. So, all right, that's a long story around. I don't like S100B, and there's no, for what I know, and we did recently also a journal cover on this. There doesn't seem to be much evidence or much reason for why we're using that. But the CT head. Again, this is my own personal opinion, not anything else than that. But okay, so CT head, if you do clinically think that this patient needs a CT head. They might be on warfarin and they have hit their head. Well, then it's a CT head. Then do a CT neck almost like, according to EM cases, they should almost always do it. I'm not sure we should always do it. Depends on the clinical like status. Are they totally fine? There are no like the head injury, the head bump is not a distracting injury, and you can talk with the patient and they don't hurt. Then I wouldn't do it, but otherwise I probably would. And the reason why is there are some studies saying that if you have the significant head injury here, there's like 20% risk of they might also have a neck fracture. We didn't go too much through the Ottawa head CC rule, but I think the cervical spine rule and the nexus rule, I just referred you to a good lecture on it. But not all above 65 should have a CT of their neck, but you should at least consider it. In the studies, they have been excluded. So, but even though they might have been excluded because of osteoporosis, because of this, I think it's reasonable to have a low threshold to do a CC neck. It's not just not mandatory. If they just fell and hit their foot and they didn't really hit their neck, then probably like we should use our clinical gestalt still, our clinical judgment still. Yeah, pain management we talked about, must be able to immobilize. And then I'll just bring you home these, bring you these from the EM cases, trauma, geriatric trauma, their take-home points. So the first one would be, one of the myths is transit to a trauma center is a life-saving emergency surgery only. Like, and that's specific for Canada, but in general, if an elderly patient needs it, they should be transferred. Prognostication of trauma patients can be accurately assessed based on age and comorbidities in the ED. That's also a myth. Volume replacement in trauma patients with hemorrhagic shock should only ever be accomplished utilized blood products. So here you have to think about the elderly are usually dehydrated as baseline. So giving a bit of so the theory of don't give blood products in major trauma is a topic for a different time, but it's usually because of the glucocalyx that you're destroying the glucocalyx. That's the theory anyway, and that like destroys the coagulation cascade, and you'll just thin the blood so that it can coagulate. So even though you might get a bit of better blood pressure, you'll just pop the cloth. As they say, don't pop the cloth with the thin fluids. But here it might be some reason to it because they're dehydrated and you actually need to optimize them. Just don't like fill them with fluids. Use blood and fluids. Then isolated pelvic fractures are a rare cause of hemorrhagic shock and mortality in trauma patients. Well, older patients, again, osteoporotic older patients may have severe pelvic trauma sometimes, so think of that. Opioid analgesics should be withheld from older trauma patients due to potential adverse effects. Yeah, it's a double-edged sword, as we talked about too much, and they might become delirious too little, and they might also become delirious. You have to treat them, but start low, go slow, and oftentimes they have to be admitted. Make sure they can mobilize. If they can't, then you have given too little. Okay. Unstable C-spine injuries are unlikely after a ground level fall. No, they're not. Anticoagulation medication should always be withheld after minor head injury in patients. In older patients, it's not a practice that I've seen in that much that we withhold it if there is no bleed. Certainly, there's a great lecture about from Jerome Hoffman, like questioning why are we doing CT scans? why are we doing CT scans after looking for subdural hematomas? Because that's what we're doing usually when we do the CT scans on these elderly patients who fall. Because right now, if they fall in, like, should we do a CT scan now? Okay, then that makes sense. Do they have a bleed right now? But that doesn't mean, like, the subdural hematomas, they usually develop over weeks to months afterwards, right? So always inform the patient's families and the patients themselves. If they turn up strange in a couple of weeks or months, then they definitely should do a re-scan. But I think there are some studies that actually show that systematically re-scanning these patients doesn't actually help anything. So you should scan them in the emergency department if you clinically think it's important, but you should not withhold their anticoagulants if you don't find a bleed, because there are some geriatric studies that says that if they have to fall, I think it was 295 times a year for it to be beneficial for them to remove anticoagulants if the anticoagulants are, for instance, atrial fibrillation indicated. So yeah. The reference is on EMK's homepage as well. So, and there's also isolated risk fractures are benign and injuries do not require treatment. And here was the important thing about that. It's important because they to treat the pain, because they might develop pneumonia. It's also might also have to have a low risk for low threshold for CT of the abdomen, throughout any solid organ injuries, because they might also have that with risk fractures, and then consider transfer to regional hospital if they have more than five fractures, or bilateral fractures or flail chest. Of course, that's more a major trauma thing. Okay. With hip fractures do not require urgent surgery. That's a problem. They have to move as fast as possible, right? There's a high risk of pulmonary embolism, pneumonia, and death, and so on if they're not treated. So it's really important that they get surgery, hopefully in less than 6 hours. And a fracture like that in a frail body, if you want to turn that around, you need to be fast about it, right? All the patients who are discharged from ED with a non-injurious fall do not require specific follow-up assessments. Again, this is the philosophy of mechanical faults are actually a geriatric decompensation mechanisms, right? You need to work them up, and you need to find out all the external and internal factors that might be the reason why they fall. They don't fall every day. Why did they fall today? If it's a pattern, then they should be followed up and try to optimize those risks, all right? So they don't fall again, or you might not be able to make them not fall again, but you might minimize the risk of falls, or you might increase the risk, decrease the risk of fractures if they do fall. Yeah. All right. Here, in the end, last couple of slides here. When do you call your orthopedic surgeons? Call for all these really don't misdiagnose, like compartment syndrome, necrotizing fasciitis, if there's no circulation, or if there's high risk of vascular injury. If you have a luxation with vascular injury compromise, like ankle luxation, usually you have to reduce it. Then it usually will become better, but that's something you want to call someone about. And then some amputations, right, and open amputations, and open Gustilo Anderson above maybe 2-3. You'll have to call someone as well, but not necessarily. You don't have to don't call even if there is an injury, like peripheral nerve damage. It doesn't have to be called right during the nighttime. You can call tomorrow morning, right? An extensive soft tissue injury, like quadriceps, you can call tomorrow morning. There are some specific fractures, like we talked about knee dislocation here. That's important. The supracondylar humerus fracture is also important. If you have the anterior luxation of the humor, of the glenohumeral anterior dislocation, that's with pulse deficits. That's also important, right? Pulse deficits in general is a really high acuity red flag where you need an orthopedic surgeon right away. Okay. And then just as a taste of, I want to do an European trauma course, or ATLS, major trauma kind of lecture at some point as well. But until that day, I'll just give you the links so you can read up on your own. So in general, if you want to start somewhere, start here with these. These are really great. Chris Hicks, Andrew Prasosoniak, and like EMKs have done these great lectures on this. For bleeding, check out these some courses. There are these courses that are really good for systematically going through it. The ATLS course is very much for everyone, like in any kind of specialty, everywhere. Then there's a lot of critique. Just check out like Scott Weingard's critique in the OODA loops and breath baking lectures. But so that's ACLS is more like if you're alone somewhere, it's not as team based. Whereas ETC, the European Trauma Course, is more team based. You're the team leader, and you do utilize a lot of non-technical skills. All right. So these are two different courses. They do a little bit of different things, but they're usually thought of as the same kind of level. And this is, I guess, the ECC is more towards someone who's working on a higher trauma center, but also someone who is more like prone to emergency medicine, where you're the team leader, because that's a role you're going to take. And here is more like you're an examining doctor as well, maybe a bit more in the wilderness as well. Yeah, non-technical skills are great videos here. Demonstrations of a trauma one call on a trauma one call where there's vital signs that are being compromised, especially low blood pressure or low GCS. These are great cases for that. And then for analgesia, check this out. Yeah. For specific injuries, I've talked about the this high energy series in Intranet and YouTube. That's really good, and they have an abdominal one as well. All right, so I will probably be making this at some point in the future. Don't know when, but thank you so much for having listened through all of these marathon lectures. I really appreciate it, and please leave some comments if you find something that I've said that is obviously wrong, or you have any comments on it, or want to discuss it, then please just leave any comments. Thank you so much.